Knock, knock. Hi guys, I'm dermatologist Dr. Abby Waldman, and I want to tell you this story of a follower who reached out to me. Recently, a follower of mine reached out to me and they said that they took 8 years to diagnose their hidradenitis suppurativa. They were having abscesses under their arms and in their groin. There were boils and drainage and pain. And they went to many doctors and they were told that they had infections, that they weren't clean enough. They were told to go lose weight and then come back and see them once that was complete. But 8 years this person was suffering, and that made me realize that there are likely more of you out there that are in the same predicament, and that I needed to get an expert in hidradenitis suppurativa, also known as HS, here to just give all of their expertise to you. And so this video will be all of that. It'll be your expert guide. And so I have here today my great colleague and friend, Dr. Alexandra Charrow. She is an expert in hidradenitis suppurativa. She's a dermatologist at Brigham and Women's Hospital in Boston. She's assistant professor of Harvard Medical School. She developed the Hidradenitis Suppurativa Clinic, and she is the director of that clinic at Brigham and Women's Hospital. And I have her here today to share all of her expertise. We discuss diagnosis, different treatment options, surgical options, what you can do at home, how you can get staged, all the information you will need if you or a family member has hidradenitis suppurativa or wonders if they do have it and is trying to get a diagnosis. So let's get to it.
Thank you, Dr. Charrow, for joining me. So in a talk you gave last week, which was incredible, you said that patients with hidradenitis suppurativa go 7 years, I think that you said, without a diagnosis. How do patients get a diagnosis of HS, hidradenitis suppurativa?
That's a great question. So it's about 7 to 10 years on average from the time of symptoms to the time of diagnosis, which is a really long time. And that means that people are interfacing with and meeting with a lot of doctors, family members, etc., before they actually get a diagnosis. The sort of gold standard is based on somebody's history. So there's no specific test that we do. We don't usually do a biopsy the way we might with something else. It's based on somebody's history and then some exam findings. So if somebody is experiencing cysts, abscesses, nodules, or things like that in the armpits and the groin, underneath the breasts that are recurrent, and that specifically often if they leave scars or tunnels or tracks, that's really suggestive to us that somebody has hidradenitis. More mild cases, which are more like acne and don't necessarily leave scars but occur in those areas of the armpits and the groin, the buttocks, or in the breast area, those are a little bit more subtle and maybe harder to diagnose and may require a dermatologist's evaluation. More severe cases in which people have a lot more scarring or tunnels, those may be diagnosed by a dermatologist, but if there's less access to a dermatologist, then they may be diagnosed by a primary care doctor, an emergency medicine doctor, or by the patient themselves.
And you reminded me of something in that same talk. You talked about how HS, we're going to call it HS, falls into two categories, like an acne type picture and a more inflammatory bowel disease type picture. Can you explain that more? I'd actually never heard that before. You were the first time to ever kind of describe that.
This may be controversial. It's how I think about it. I sort of think about it as a spectrum. And on one end are people who have more acne-like disease. It's going to respond more to acne-like treatment. And on the other side are people who have more inflammatory disease with a lot more inflammation. Obviously, acne also has a lot of inflammation, so it's not necessarily a clean-cut difference between the two. But people who have things that look much more like big pimples or pustules or blackheads, they don't tend to have as much scarring, tunneling, and big abscesses that form and destroy the area. The people who have bigger abscesses or bigger pockets of pus and then create tunnels in the skin, those people have much more inflammation and their disease looks a lot more like Crohn's or inflammatory bowel disease, but on the skin itself. And they I like to think of them that way because the people who have more Crohn's-like disease, they tend to respond more to Crohn's-like treatment. So that's biologics, injection medications, antibiotics, and steroids. The people who have more acne-like disease, they tend to respond more to acne-like treatment. So hormone-related medications like spironolactone or birth control to specific washes. And a lot of that has to do with sort of how deep the disease is in the skin. Once you have a lot of tunnels and a lot of abscesses, a cream is not going to penetrate deep enough. You need things that are systemic and that affect the body more systemically.
That makes a lot of sense. When patients come to you and they say, Dr. Charrow, what is causing my HS? What do you say?
Well, it's not their fault. It is often related to a combination of things. We don't actually know really what causes hidradenitis per se, but we know there are specific risk factors that make it more likely that somebody could develop it. So things that are risk factors for HS include family history. So people often have the disease running in their family. And one thing that we know is that people sometimes aren't always really open about their disease. And so somebody will get a diagnosis and then they'll find out only after they got a diagnosis, oh, my grandmother had these boils that were pretty similar, or somebody else had them. So family history is pretty common and runs in families, and we know there are some genetic factors that are associated with it. And there are a lot of really amazing doctors that are trying to figure out what those genetic markers are, and scientists too. The second is smoking, which we know actually any nicotine product can make hidradenitis worse. And that includes vaping and various other nicotine products, or nicotine is mixed in with any other thing that somebody is smoking or ingesting. So we know nicotine has an effect on hair follicles and makes that worse too. We know rubbing, friction, and things like that can make it worse. And we know that people have worse disease if they have higher weight. But we don't know necessarily if when people lose weight, they always have more improved disease. So some people have noted that for themselves.
Oh, that's interesting, because I actually see that a lot in people asking, does weight loss help? Because I feel like a lot of anecdotal evidence, a lot of anecdotes is that they'll say, well, I was told to lose weight. I was told that my heavy weight was causing this, but then they lost weight and it either got worse or it made no difference. So that's really interesting to hear you say that.
Weight is very controversial, and I think it's very hard if people go to see a doctor and the first thing that they're told is that they need to lose weight, which is both a really challenging thing for people to do and also may not be something that people can do or want to do. And so I think to be told that that is the singular way to make their disease better when there isn't enough data to suggest that right now is, I think, really tricky. I think with the proliferation of medications like Ozempic or Mounjaro or things like that, we may start to have better evidence for what weight loss does for HS. And I think we'll have a bigger set of people who take these medications and maybe notice benefits from the medications because of weight loss, or notice benefits from the medications even if they don't lose weight. And that would help us to figure out what is driving the disease more. We do know that having elevated sugars, which may or may not be associated with somebody's weight, can make HS worse. And then there are a few other sorts of risk factors that people may have in their lives that can make it worse too. Sweating, friction, things like that can make it worse. But again, it has to be a combination of all these things, and there are a bunch of other factors we haven't identified that definitely make HS worse. So I really would emphasize, if nothing else, that we don't understand this disease well enough to say to somebody, this is the exact reason why you have it, but we can definitely help people identify things that may be exacerbating their disease or maybe making the risk that they already have worse.
Do you ever test for insulin resistance or diabetes in patients?
Yeah, so some people come to me and they think that they have a family history, they have signs on their skin that they might have insulin resistance, and we'll test them then. And then we run a host of labs before we start patients on medications, and we'll sometimes add that in if patients are curious, and that can be helpful. But it's more helpful in directing them to the sort of overall picture. There are a bunch of recommendations about who should be screened and how they should be screened for other things that are related to HS. And we try to do that screening too for various conditions that are associated with HS.
What are those conditions?
So diabetes is associated with HS. Type 2 diabetes is associated with HS. We know that some cardiovascular diseases are more associated with HS, and we don't know whether that's just because a lot of patients who have HS are heavier or whether it's because patients who have HS have inflammation, and inflammation worsens cardiovascular disease. We know hidradenitis is associated with inflammatory bowel disease like Crohn's and ulcerative colitis. We know it's associated with acne and kinds of severe acne, and we know it's associated with pilonidal cysts, which some people consider a variant of HS, and this condition called dissecting cellulitis, which is almost like HS but on the scalp.
Right. So before getting into medications, because you talked about medications, what are at-home treatments that someone who has really early HS or maybe is waiting to see a doctor, maybe suspects that they have HS, what type of treatments could they use at home?
So before I get into all the things that people can do at home, I would say that there are some amazing resources that are directed to patients that are out in the world that I would emphasize people take a look at. One is the HS Foundation, and there's also Canadian HS Foundation for Canadians. And though the HS Foundation has a lot of resources that are directed for patients that are helpful for finding specialists in your area, and that may be helpful for finding more information, and that provide plain language summaries, so summaries of articles that are out there in the literature. And that can be super helpful. There's also a patient-directed pamphlet that's online called Papaya that gives information to patients about hidradenitis, about what causes it, about how to help in cases of flares, etc. So that can be very helpful too. But you're asking,
we'll include links to all those in the
great. Yeah, but I would really emphasize that those two resources are pretty invaluable. In addition to those, there's a bunch of conferences every year that are hosted by the HS Foundation and others that are more patient-directed, which can also be helpful.
Oh, wow.
Too. But if you're having flares, there's a lot of things that people can try to do at home, and there's some good evidence for them. So one thing that we recommend to patients is that they use warm compresses in the area to try to keep the area open if it's a big cyst. If it's getting really, really painful, then they should definitely see a doctor or a provider if they can. But warm compresses or things like that can be helpful. Sometimes people will prescribe medications, either pills or creams that can be used in the area when they're really painful. A lot of people will try drawing salves or will try to open it themselves at home. And then when I see patients, they feel embarrassed about that. But I think I can understand where if you're in duress and you've seen a lot of people before and never been given a diagnosis, why that would be a very reasonable option for you.
Yeah. What about, I feel like what I see a lot is like asking about HIPAA cleanse and bleach baths and things that kind of decrease sort of super infections on top of the HS.
I like those as a preventative strategy. So I think using HIPAA cleanse, using benzoyl peroxide products. So there's a bunch of benzoyl peroxide soaps. HIPAA cleanse is chlorhexidine soap. So that's a brand name for it. But either of those are great antimicrobial soaps people can use. Other things that people can use to decrease the microbial burden, especially if you have more like acne-like disease, is taking vinegar soaks where you put 2 cups of plain vinegar or apple cider vinegar into a bath. You'll smell like salad dressing at the end of it, but it does have a lot of good antimicrobial properties if you're looking for things to do at home and as a preventative strategy. Everyone asks about diet, about what people should be eating, and we really don't know. What we do know is that the more varied your diet, the healthier your gut microbiome can be. And there's some evidence to suggest that the good kinds of fermented foods, so that would be things like kimchi or kombucha or plain yogurt, may be helpful for the gut microbiome. But we can't then say, okay, if you eat those things, your gut microbiome is going to be healthier and then you're not going to get HS or you're not going to have your HS. We don't have that level of data yet. So I can recommend those things. I especially like to recommend them because I think it's good to add things, especially because people get really worried and try to subtract things, right? And I worry about people getting disordered eating or having a very restrictive diet where they're eating just, chicken and rice and nothing else. And so we know we steal from the acne literature a little bit in terms of dietary modifications that may be helpful for HS. So there's relatively good evidence in the acne literature for avoiding whey protein, which is found in protein shakes and protein powders, and moving towards, if you're trying to get swole or big, to add on pea protein or things like that. In terms of other things we know from the acne literature are high glycemic diet, so plain sugars, which are in candy and all sorts of things that are in processed foods and are very hard to avoid in an American diet. Those things maybe also mediate acne and therefore maybe mediate HS.
When you mention whey protein, it's a milk protein. Do you also recommend avoiding milk or other dairy or just whey?
For now, the best evidence is for avoiding whey, but a lot of patients will themselves avoid dairy, or they'll avoid dairy and plain sugar and a bunch of other things. Again, I think it's okay to try these. It just would be, I really try to emphasize, if you try it for a few months and you're not noticing a difference, please reintroduce those foods. It's better to have for your social life, for your other life, to have a varied diet. So if you notice it's working for you, great. You can slowly start to add things in.
Give me a sense, if someone is coming to see you, they have a diagnosis elsewhere, or maybe they suspect they have a diagnosis, what is a visit with you like?
So that's a great question. So we try to discuss the patient. For our first patient visit, we're spending a lot of time determining sort of what the history of the patient's disease is, when they started to have symptoms, when they were diagnosed, if they were diagnosed, or if they're coming here for a diagnosis. And then once we've established sort of what the history is of their disease, what things they've already tried. So what creams, what pills, what oral medications, what biologic medications, what vitamins they've tried, all the things that they've already tried and what has been beneficial to them and what hasn't. And then we do an exam and take a look to see sort of if we agree that it's a diagnosis of HS, if there's some question about it. And that means, an exam like a lot of dermatology, these are pretty intimate exams. That means they were taking a look at the armpits, at the groin, at the breasts, at the buttocks. Not everybody wants to do that. And if they don't, then we can always save it if we need to. But it's hard to establish a diagnosis without taking a look at the actual scarring that forms there. And then the last portion, so once we've done the history and then a physical exam, the last portion is discussing the sort of management plan for that patient based on what's worked for them already, what their exam looks like, and what things we think might be best for them. We try to break that into 4 parts. So like a flare management plan, so something that the patients can do at home if they're flaring, which usually involves some medications of some kind. A maintenance strategy, so something to prevent flares from forming. Review of lifestyle modifications are things that may be helpful for them to do at home to help make the disease better, which we've already kind of discussed here. And then last, if it's relevant, surgical options that may be available.
I'd love to get into that, but I had some other questions. What, if it's not HS, if you have abscesses under your arms and in your groin, what other things are on your differential? What else could it be?
Oh, such a good question. So there are some mimickers of hidradenitis to think about. One mimicker of hidradenitis is staph infection, and that gets really complicated because hidradenitis often is colonized by staph,
right.
Which is a kind of very sticky bacteria. So just because there's staph there doesn't mean that it's not HS, and just because there's not staph there doesn't mean it's also not HS. But sometimes patients come in and they have spots that are outside of the typical areas we might see HS in. So big, almost like folliculitis or boils that are on the flank or on the outer buttocks. And that's much more suggestive of a chronic staph infection or people being colonized with staph and then getting infected over and over again. And staph can live on our pets, it can live in our nose, it can live in our buttocks. And so it's hard to get rid of, and people can keep getting these infections with staph. And so if I don't see a lot of scarring, and I see that staph is mostly in areas outside of the typical areas, sort of near but not in them, then we think more about staph infections. There are a few really, really rare sexually transmitted diseases that people can get that can cause groin swelling and inflammation, and that may mimic HS. And then Crohn's disease can mimic HS, especially in the buttocks or in the perineum, which is the area between the genitals and the buttocks.
And when that occurs, do most patients have a diagnosis of Crohn's disease to begin with?
For the most part. Occasionally, patients will come in and they'll have no diagnosis of Crohn's disease, but they have disease that looks sort of like HS and sort of like Crohn's disease. And then we will work with our gastroenterology colleagues who are excellent to try to figure out if maybe this is all representing Crohn's disease.
Gotcha. So tell me about staging. So you talk about exam. Is there a component of staging HS?
Yeah, so there is a staging process for HS. It is relatively blunt and primarily a surgical staging process, in which there are 3 stages. The first is stage 1, which is disease that does not have a lot of scarring or really any scarring at all. Stage 2 is when you start to see scarring and tunnels that are present. And then stage 3 is where an entire area of the body has scars and tunnels and abscesses that are forming without any typical or normal skin in between. So if an entire armpit is involved and has tunnels all the way through without any normal skin between the areas that are affected, then that would be stage 3.
Gotcha. That's very helpful. I did not know that. So a patient has come to see you and you're examining them. And then what would be like a pretty basic case? Maybe you have mild disease. What would be the first medication you would try?
Usually the first thing we're doing is like lifestyle modifications, washes, things like that. So that would be like thinking through benzoyl peroxide strategies or other soaps, things like that may be helpful for patients to prevent new spots from forming, and maybe giving them a topical cream to use if a spot comes up that's really inflamed. That's especially helpful if people have disease where the big spots are still pretty small. So if the big spots are still the size of a grape or smaller, then topical strategies may be most helpful.
Okay. And what are those topicals? Is it like topical antibiotics? Is it topical steroids?
So usually we recommend a topical steroid for when a patient has flaring or an exacerbation. So when they have a really painful spot, we'll usually recommend a topical steroid. Not everybody does that, but many of the HS specialists will recommend something like that. Or injection of a steroid, so they'd come into the office to get an injection. And then some sort of wash or sometimes a topical antibiotic to help prevent new spots from forming. The topical antibiotics tend to develop resistance pretty quickly and aren't always effective. So while we prescribe them, they're really best utilized for people who have very mild disease.
Gotcha. How often should you use these washes, like the chlorhexidine or the benzoyl peroxide? Is this every day, twice a day, every other day?
I think there's so much stigma around a hidradenitis that patients feel like it's because they're dirty or they're not clean enough, etc. And I think that idea makes people feel like they need to be washing a million times a day.
Right.
We usually recommend these soaps 3 times a week and to just to the areas that are affected, right? And especially because we're in the business of trying to keep everybody's skin healthy, and a lot of these soaps can be very dry. And we live in Boston, which is like 70% of the time extremely dry and cold, and 30% of the time extremely humid and hot, which is like really a good setup for eczema for people. So I try to say, like, wash as you ordinarily would once a day, use these soaps 3 times a week. That should be beneficial. If it's not, you may need to escalate therapy, or you may have more severe disease, or there may be that the microbial component is only a very minor portion of the disease.
So then let's say someone comes in and has more significant disease. They're having regular flares. Maybe they're having some tunneling, some scarring. What would be your first medication? What would people expect to kind of consider as their options?
This is in active debate right now. So, we do not yet have perfect national guidelines as a HS Foundation or as part of the HS Foundation or as HS specialists to determine what exactly would be the next line of treatment. The recommendations have for a long time been to start with a 3-month course of oral antibiotics and then move on to a biologic or injection medication. And those are dependent on the severity of the patient, not necessarily the early staging, but based on how much the disease is affecting the patient, what areas it's affecting, how much pain they're in, etc. And based on those, patients may qualify for or need to be on an injection medication, like a biologic. Those medications we try to initiate as early as possible, even for young people, if there's signs of scarring or tunnels or sinus tracts or things like that, because we really want to affect the disease before it becomes only a surgical disease, right? Once people have very, very, very severe disease, the medications are only going to prevent new stuff from forming, but they're not going to help clear away big tunnels or big abscesses. And then that part of the disease becomes primarily surgical or procedural.
Gotcha. I know that practice changes, and I'm sure this is a rapidly changing practice, but what is your main biologic that you use?
So we are very lucky. There are currently 2 FDA-approved treatments for HS. So one is secukinumab, which is Cosentyx, and the other is adalimumab or Humira. And adalimumab was approved in 2015, 2016, sometime around then for HS. It was the first medication that was approved, and it's approved for a bunch of different conditions. So it's approved for psoriasis and psoriatic arthritis and Crohn's and ulcerative colitis and uveitis and RA and a bunch of other things. And then secukinumab was just approved for hidradenitis in November of 2023. And It's approved for psoriasis and psoriatic arthritis and HS. And I think I'm probably missing a few other things. And so we try to determine which you would start with based on somebody's comorbidities, their comfort with certain kinds of medications, how often it's going to be injected, the degree of immunosuppression that they need, speed at which they need it to work, etc. But we don't yet have solid recommendations for who should be on one versus the other. The determination is based on those sorts of factors. Eventually, we may be able to say, like, this is going to be the first line, and this is going to be the second line, and this is going to be the third line. But we don't really have that. We don't have that degree of freedom right now because we don't have enough FDA-approved treatments.
So basically, it sounds like it's a conversation between you and your doctor. So if you are going to be on a biologic, it would kind of depend on sort of their practice and sort of your symptoms. Does that seem right?
Yeah. So if you're going to be on a biologic, yeah, it will depend on their practice, your symptoms, your comorbidities, things like that.
Are there comorbidities that you think about where you just, like, that is not an option for you? A biologic would just not be something you would consider?
For the most part, no. So if somebody's very immunosuppressed for another reason, or they have cancer that they're undergoing treatment for, then they're more restricted in terms of their treatments, but they are not precluded from treatments. And then there's some kinds of diseases that people can have that may push them towards choosing one over another. So if you have MS, multiple sclerosis, you really can't be on the class of medications that Humira or adalimumab is in. If you have active Crohn's disease that's not well controlled, then you really can't be on secukinumab or Cosentyx. And so it's really about trying to weigh the kinds of comorbidities people have to determine which choice you would want for a patient. And you'd think this doesn't come up that often, but it actually does because HS is so common that it can co-occur with a lot of other conditions.
Yeah. What can people expect in terms of, like, if you are going to be on a biologic, is it something you take for life? Is it something you take for just a shorter amount of time? How long are people usually on these medicines?
People are usually on these medications for a long time or for as long as they are effective. So the thing that limits us is whether they stop working for patients or whether the patients develop immunity to them, or whether their disease becomes more severe, or they have vacillations in their weight that affect the absorption of the medication, etc. But otherwise, we try to keep patients on these medications for a long time because the alternative is that patients develop scarring and tunnels and pain and all sorts of things that really affect somebody's quality of life pretty significantly.
That reminds me of something that I thought was so cool in your talk last week, that you in your clinic actually test the levels of the medicine and you can see if someone is getting immune to those medicines. Tell me more about that.
So this is a practice that many people who treat patients with hidradenitis will now do, which is that we will check the lowest level that somebody has of these medications. So there's a few medications that we prescribe to people. So we don't just prescribe the 2 FDA-approved treatments. If somebody doesn't respond to those 2 FDA-approved treatments or they can't be on them, there's a few other biologic medications that are similar that we'll sometimes use, and we'll measure the amount of that medication in somebody's body. And if it's really low, then that can help us determine what we want to do next. So if somebody has been on a medication for a while, it's been working really well, and it's not working anymore, then it's time to say, okay, maybe we should measure the level of this medication. If the level is really low, and the person has developed an immunity to that medication, we should be thinking about switching them to something else. If the medication is really, really low and they haven't developed immunity, then maybe should be increasing their medication. And if the medication is not working, but their levels are really high, then we start to think to ourselves, maybe this medication is not the right choice for them at all because this mechanism is not mediating their disease.
Right. Wow. That's really interesting. So I know that you are one of the only doctors in the Boston area anyway that does this de-roofing surgical procedure. Tell me a little bit more about that.
Yeah, so there are a few doctors that are doing them in Boston now, which is great. You can go to the HS Foundation website to take a look and see who might be in your area doing these procedures. In Boston, there are actually quite a few HS specialists, and some of us do these procedures, which is really great for patients. And then there are plastic surgeons who do much bigger surgeries. So I know you're a surgeon, so you're thinking about this surgically too, and there are a few different surgical options for patients. The first is de-roofing. That's what we do in our clinic. This is where we essentially find the areas where the patient's disease has traveled to, what tunnels have been made, what pockets have been made, and we try to clear out all of the biofilm, that's the bacteria at the base of a lot of these tunnels that then makes them very hard to heal. So we clear those out, and then we let the whole area heal from the bottom up. And there are advantages to that and disadvantages in that model. There are big surgeries that our surgical colleagues will do here. So there are plastic surgeons who we work with, and there are many plastic surgeons out in the US who will do big surgeries where they cut out the whole area and then sew it up. There are some general surgeons that will either do that or will do deroofing surgeries like we do, like the dermatologists do. There's laser treatments, which are sort of doing what the deroofing is doing, where they're destroying the tunnels and then letting the area heal up. And then some people will even do these surgeries that are involved using liquid nitrogen or very, very cold areas to burn the skin or burn the tunnels. They're all kind of doing the same thing, which is that they're destroying the tunnel or destroying part of the tunnel to help heal the whole area up, because there's no way to get rid of the tunnel from what we know right now without doing something like that. There are some excellent dermatologists who are studying different ways that may be outside of these modes for getting rid of HS. So whether that be with smaller procedures or punch procedures, or by putting material into the tunnel, like high potency saline that maybe can help to destroy the tunnels, or certain kinds of astringents that maybe help to destroy the tunnels too.
Oh, interesting. How do you decide when someone should get one of these treatments?
I decide based on somebody's history. So what they're telling me, if there's a spot that is always draining and has not stopped draining even while they've been on medication, or they have one spot that is draining and they don't have any other spots that are involved, if they typically get recurrence of flares in one or two areas, or they have a lot of one anatomical area, one part of the body that is always affected, so their whole armpit has tunnels throughout, or their buttocks or something like that, that sort of pushes us more towards thinking through, well, maybe we should get rid of this spot because this is the spot that is causing people trouble. Now, they still probably need to be on some sort of medication all the time so they don't develop a new spot that becomes the bad guy, right?
Right. I remember you saying that a lot of times patients are frustrated because they can't get general surgery because the surgeons, rightfully so, have them lose weight and stop smoking before surgery, because those are big risk factors for going under general anesthesia and getting a large surgery. Does that affect your decision to do a deroofing?
Not usually. I think I've never restricted somebody's surgery based on their tobacco use or their nicotine use or their weight. But I can understand where somebody might make that decision if they're putting somebody under general anesthesia, or if they're cutting and sewing, because when you sew, you want the area to heal well, and nicotine and tobacco use can affect that too. In general, the restrictions that I have are based on my own comfort with the size of the area that's involved, our ability to numb the area, because we can't put people under general anesthesia. We're numbing these areas with local anesthesia, meaning we're injecting anesthesia into the area. And there are limits on how much we can use safely in somebody. Okay. So if somebody has a very big area that's involved, there's limits to that. And then there are nutritional concerns. I've had a few patients who I have not felt comfortable doing surgery on because I've worried that they are losing weight very rapidly. There are signs that they are wasting, right? They're like becoming skinnier and skinnier, and they're not going to be able to heal properly because they're so ill chronically.
Right.
That's been the only time that I've had really big restrictions are size and nutritional status.
Right. It's really incredible what you're offering. I think that's really amazing treatment for patients, this deroofing surgery and other surgical treatments that really provides a huge relief. So it's amazing what you offer.
We're really lucky, and I think we're lucky in Boston. There's so many excellent people who are treating HS patients, and we're lucky to have such a great community of doctors who treat patients. I think there are a lot of areas of the country, there are some excellent HS specialists, but we still have room to grow, and there are plenty of places in the US where it's much harder to find somebody who specializes in HS or who does procedures like this. And I think that can be a really big challenge for access for patients.
Do you have anything else that you'd like to add, like any future treatments or anything else that you just want to add?
Hidradenitis is an ongoing area of study, both in terms of new medications. So there's a lot of clinical trials out there for patients who are interested and who have disease that maybe merit participating in a clinical trial. There are a lot more resources out there than there used to be, but there are also places where I'm sure we're not meeting the needs of patients, and we always want to hear about that too. And our hope really is to figure out as best as we can what is driving this disease for patients and help people thrive and not suffer the way that they have. So I would direct everybody to the HS Foundation website if they can, to some of the patient-utilized resources, and I think those can be really helpful for patients and for their families.
Thank you so much, Dr. Charrow. This is incredible. I think it is going to be incredible help for so many patients out there. Thank you so much for your time and expertise.
Thank you. Thank you so much for having me. This is so great.
Of course.
So please like this video and comment if you got value from it. Please subscribe. The goal of this channel is to be like having a dermatologist in the family to answer questions about your dermatology and skincare concerns. Having all the information that we have as doctors out there for you. I'm Dr. Abby Waldman. Be well.